Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Medication, causes of hypertension. It is important to be aware of the medications that can cause high blood pressure to best treat your patients. Today we're going to talk about a treatment for prostate cancer, Abiraterone, more commonly referred to as Zytiga, which can cause high blood pressure. But before we get into it, make sure you check out the other videos at this channel. Check out bcnephro.com where you'll find articles not only on this subject, but on a wide range of nephrology topics. I'm also on Instagram at bcnephro. But now, let's get into it. An important component of treatment of metastatic prostate cancer is androgen deprivation therapy, as the tumor growth is driven by testosterone. Abiraterone is one form of achieving this, specifically by decreasing androgen production in the testes, the adrenal glands, and the prostate tumor itself. Also, in this process, it causes hypertension. It does this by causing pseudo hyperaldosteronism, also referred to as a syndrome of apparent mineralocorticoid excess. This is a state where there are clinical findings of hyperaldosteronism, specifically hypertension, often associated with hypokalemia and metabolic alkalosis, but the aldosterone levels are not elevated. The way Abiraterone achieves its clinical effect of decreasing androgen production is by inhibiting an enzyme resulting in decreased activity of 17-alpha hydroxylase. This is the same enzyme that is impaired in one of the forms of congenital adrenal hyperplasia. 17-alpha hydroxylase is necessary in the process of conversion of cholesterol to androgens. Initially, cholesterol is metabolized to Prednisone and progesterone, and the 17-alpha hydroxylase is the enzyme that catalyzes the next step in this biochemical pathway. This conversion of Prednisone and progesterone is also necessary in the pathway of biochemical synthesis of cortisol. So therefore, patients treated with this not only have decreased androgen levels, they have decreased cortisol levels. Because there are decreased cortisol levels, there is not negative feedback, and there's increased production of ACTH. The ACTH is produced in an attempt to raise the cortisol levels, but of course the cortisol levels cannot be raised, so there's an accumulation of the precursors corticosterone and deoxycorticosterone. Corticosterone has glucocorticoid activity, so these patients do not develop clinical manifestations of adrenal insufficiency. Deoxycorticosterone has mineralocorticoid activity, and this causes the findings of hypertension, hypokalemia, and metabolic alkalosis. The enzyme 17-alpha hydroxylase is not necessary for the production of aldosterone. However, aldosterone levels in this situation are depressed. This is because of the effects from the deoxycorticosterone, namely volume overload and hypokalemia, impair the release of renin and aldosterone. As this medication is being used for metastatic cancer, discontinuing it is a less than ideal option, so there need to be other treatment options for the hypertension and hypokalemia. Given that this pathophysiologic process is driven by elevated ACTH levels, the mainstay is to prevent the elevation of the ACTH levels by use of low-dose glucocorticoids. This is done with low-dose prednisone. Initially, prednisone at a dose of 5 milligrams twice daily was used with this medication. Currently, more commonly, this is decreased to prednisone 5 milligrams once a day. Abiraterone is always given concomitantly with some dose of prednisone. However, even with prednisone, a significant percentage of patients will still develop hypertension, about 1/3 on the 5 milligram once a day dose and 10% on the 5 milligram twice daily dose. The next treatment option would be to use a mineralocorticoid antagonist. Now, the most common mineralocorticoid antagonist is spironolactone. However, this should not be used in these cases. This is because spironolactone is not specific for the mineralocorticoid receptor and can actually activate the androgen receptor, which is what we're trying to avoid in prostate cancer. So an antagonist that is specific for the mineralocorticoid receptor should be used, and that is Eplerenone. Another treatment option is use of the potassium-sparing diuretic Amiloride. Amiloride blocks the ENaC epithelial sodium channel. This is the channel that is upregulated by the mineralocorticoid receptor. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Please share this video with someone who you think might be interested in learning about this subject. It's spreading the message word of mouth that really helps the channel grow. And leave a comment. Do you have experience with hypertension, pseudo hyperaldosteronism caused by Zytiga, or do you have questions about other medications that can cause high blood pressure? And until next time.